Welcome to this video from MSK Sonography. I am John Ostrovskis. Today we're going straight into a demonstration of hand scanning for typical climber's injuries. So first of all we're going to do an A2 pulley static and dynamic assessment, and we're going to look at some collateral ligament assessments of the proximal interphalangeals and the distal interphalangeals, and we're going to look at some lumbricals, and we're going to have some case studies interspersed with the demos. So first of all, to go on to the A2 pulley, which is obviously distal to the metacarpophalangeal joint. So we've got the level of the metacarpal just here, and that's the first phalanx. So that's actually the A1 pulley there in short axis. So, and that's the flexor unit there, flexor digitorum superficialis and profundus lying beneath there. So if we come slightly distal, one can make out the contour of the A2 pulley just through there, and just keep your finger in that same position still, don't move. You can see the pulley, the A2 pulley just in here. Now if there's an A2 pulley injury, as you'll see in the case study that we'll present in a moment, you're expecting to see a hematoma through here, probably hematoma between the bone and the tendon. And if you perform a dynamic test from this position, pull that finger up to the ceiling, pull up and hold, and pull up and hold, and pull up and hold. You can see that the area here, the bone stays in contact with the tendon and there's no gapping through there, whereas in the case study we'll see that there's a massive shift of 4 millimeters indicating a full tear of the actual pulley. And whilst we're in this axis here, we can come up through this area here. That's the proximal IP. You can see the volar plate clearly in this area here. And that's the area of the A3 pulley, and the area of the A4 pulley coming into view just through here. And we've got flexor digitorum superficialis inserting in this region, and we come up to the dip, the distal interphalangeal joint of the A5 pulley, which is often difficult to see. And we find that from a functional perspective, it's not so significant as far as injuries go. And that's the insertion of the flexor digitorum profundus in this area here. So now we're going to cut straight to the case study of the climber who ruptured his A2 pulley. This is a case presentation of an elite climber who was bouldering 3 weeks prior to this assessment. He was bouldering indoors, and late in the session on an open pinch he heard a loud noise in his hand and there was significant pain. He initially rested it for 2 weeks and he found that it was no better, so he gave us a ring to see what we could do. You can see from this split screen, with the left screen obviously being the injured side and the right side being injured, there's a gap between the tendon and the bone of the proximal phalanx. This displacement leads us to suspect there's a full rupture of the A2 pulley. And there's hematoma above and below the tendon. Onto a split screen of the injured tendon in both long and short axis. In the short axis, you can see there's hematoma above. But what isn't obvious here is the displacement off the bone. And that's just due to the pressure of the transducer. No matter what you see on a still shot, you need to perform a dynamic test. And you can see the dynamic test here. The left side is to the MCP. The right side is to the proximal IP. So the fluid above the tendon, that's the region of the A2 pulley. This still shot is a long axis capture from the dynamic test performed before. And this was the greatest displacement seen, and you can see that it's greater than the 4 millimeter, which is the threshold to suspect a rupture of a single pulley. It's of note here that from a clinical perspective, we could not feel, or we could not palpate a displacement. And through this, one can erroneously suspect that it's a partial tear only, but from a sonographic perspective, you can see that there is obvious displacement of bowstringing of the actual flexor tendon complex.
In this long axis view, you could see the A3 and the A4 pulley quite clearly. They look fine. The A3 is slightly more pronounced than normal, but that's due to prior history. There was no pain here and there was no instability here whatsoever. So we concluded that the injury was restricted to the A2 pulley only. It's also important to scrutinise the volar plate. This cannot be seen clearly in this shot, but it was performed sonographically during the session and there was no abnormality found there. 10 weeks later, i.e. 13 weeks post-injury, the patient attended for further assessment. On the dynamic test, you can see there is some stability there, with the displacement measuring 1.8 millimeters. This is still greater than the uninjured side of less than half a millimeter. The patient reported that for the previous 2 weeks he'd been training at 100%. Due to the findings of this assessment, we suggested that he back off a little bit and he needed to wait for another 4 weeks for the area to stabilize further. Up till then, we suggested that he didn't go beyond a 70% effort on the injured hand. And this conforms to the general advice that we have been given, that it does take a good 4 months or so for these injuries to heal.
So we're assessing the IP joints now, the collateral ligaments, and over here we've got the proximal phalanx, and then we've got the middle phalanx, and this area here is the region of the radial collateral ligament. One important test is to see if there's any instability with any injury through there, and in the demonstrations, in the case studies, you'll see instability with avulsion, and another case study, instability without avulsion. This is uninjured, so if you can see how we're putting a force through the joint, you can see there's gapping in the joint, but that feels, there's a nice strong end feel and that feels stable. So that's the proximal interphalangeal joint, the PIP, and if we go on to the dip, you can see the contour there, and we can actually see that the area is stable. And we go into the ulnar collateral ligaments. Again, it's important to assess for stability. And this is what you expect to see with an uninjured finger. So the pathology you're really looking for in these cases: are there any avulsed fragments obvious through here? Is there a continuity of fibrillar pattern through the actual ligament? And does it look stable? And does the test reproduce the pain? And we'll go on to the case studies now.
In this case study, this patient injured his left middle PIP ulnar collateral ligament 3 months prior to attending for treatment. He was climbing, his hand was in a vertical crack, his feet popped, which means his feet slipped off a hold, and he shock loaded his left hand with his middle finger stuck in it, which means he took his full body weight suddenly. There was immediate pain, and prior to this injury he was climbing to the level of 7B between 3 to 6 times a week, and he was 3 months later he's down to twice a week, climbing up to 6A occasionally, extreme sensitivity to touch and lots of pain through the day. Now this is proximal here, that's the proximal phalanx, that's distal, that's the middle phalanx. Through the area here you can see the hypertrophy of the ulnar collateral ligament, and if you keep your eye through here, as we scroll through the dynamic test, you will see that there is a darkened area which in all probability relates to the actual area of torn tissue. You will see that there is no evidence of bony avulsion. This looks like soft tissue injury only. So as we scroll through, creating a force through the joint to create movement as was demonstrated in the video, you can see that there's movement, and there's a bit of a darkened area, quite a darkened area through the middle of the joint, through the ligament area, especially in this region here. And there seems to be a bit of a shunt, a lateral shift through the joint, which changes after a few weeks of healing. This is in total contrast to what we found on the radial side of the joint, the radial collateral ligament, which looks rather normal, no sign of hypertrophy. And on dynamic test, as we scroll through, you'll see that that looks far more stable. 3.5 weeks after initial assessment, following 3 sessions of focused shockwave, we rescanned the area, and the ulnar collateral ligament is still thickened. There's hypertrophy that's totally visible, but as we scan through, you can make out that it's actually in a smaller area. The area, there's more of a fibrillar pattern, and the hypertrophy seems to be in a more centralized region only. And through the test, through the dynamic test, there seems to be more stability. The patient subjectively reports more stability, less pain on daily movements. There's a far better, stronger end feel. With this test, it's difficult to prove that this is sensitive enough to prove that, but there's a sense that this is more stable.